Thank you. That was great. I'm going to try to complement that beautiful talk with some updates on the clinical side of things that have occurred since the last gathering of this group. And I certainly appreciate the invitation to do so. It's an honor to be here. Disclosures are listed here. And my talk will also cover, in a complementary fashion, some of the topics that were just discussed. As I go through the literature since the last symposium, I have seen a lot of more detailed clinical descriptions of the enthesopathy in the literature. There's also been an interesting focus on the transition from childhood care to adult care, which I'd like to mention. The papers have now been published that actually look at the bone biopsies after what happens with burosumab, and an assembly of the multitude of data height points that were taken in some of the clinical trials have been assembled, and growth curves have been constructed that actually define what the growth is in childhood with this. There's been an update of the FEX mutation database, which has been extremely helpful for people to understand if their mutation is meaningful or not. And there's now data that takes the original trial reports that were relatively short-term for either 6 months or 1 year of therapy, and have now followed those cohorts out for 2 or 3 years, and the data now is available to review the potential durability of burosumab. So to start with, I too will mention some enthesopathy, more based on clinical survey data. The first of these papers is Dr. Javed's group, and in this study, 3 groups of adult XLH patients were reported on. They had never been treated prior with burosumab, and he's really looking to avoid problems of ascertainment bias. He looks at patients that participated in the clinical trials. He looks at another group of people that responded to an online survey about enthesopathy, and then he takes a third group in which the survey respondents are culled for the severity of their pain, so that the idea being that, is this enthesopathy as common in the painful group as in a broad group that would respond to these surveys. The results are categorized by age, and a variety of musculoskeletal complications in addition to enthesopathy were examined. So this slide just shows you by decade. On the y-axis is the percentage, and by decade you see the incidence of these various complications. We're focusing really on enthesopathy here, but you can see that fracture, osteoarthritis, osteophytes, and spinal stenosis are all shown in this important data. And you can see that you're running in a 20% in the clinical trial group here, much less in the survey group. It bounces up a little bit if you take the severe pain group of the survey. Now, this all increases when you go up 10 years to the 30 to 39, even further in the 40 to 49. And the large panel is greater than 50 years. And you can see now the axis changes such that all the groups are much more comparable by the time you're older than 50, and that the incidence of these various musculoskeletal complications are really pretty common. Osteoarthritis being the highest in the 70% range, but the enthesopathy 35 to 50%, and the spinal stenosis, which I've generally thought of as a fairly rare complication, is close to a third when looking at the whole group. Now, a second study came from Japan in which the x-rays were available, And people went through a variety of imaging techniques to try to define in detail what 25 adult XLH patients in Japan, how they were affected and the severity. Radiologists looked at these images, they categorized the lesions and graded them by various radiographic indices. And what was interesting is we know older people get enthesopathy, but they compared the incidence of these changes in the XLH group to the general population in Japan. And by the way, Japan is a country and a society in which ossification of the longitudinal ligament of the spine is extremely common, much more common than in the West. They also correlated their findings with other variables. And you can see here that in the general population in Japan, the ossification of the posterior longitudinal ligament occurs in about 2 to 4% of the population. In adult XLH, in this study, was 32%, so roughly 10 times that in the general population. Now, this KL grade is a severity of hip osteoarthritis, and you can see at the hip, the general population is affected with this degree of osteoarthritis at about 16%, where almost every adult XLH patient in this study had that severity of hip osteoarthritis. If you step up the severity by a notch, the incidence in the general population comes down significantly, but only minimally diminishes in the adult XLH group. The knee changes are there, but they're not too different from the general population. A little more, but not as dramatically different as at the hip. And you've seen these slides as per the last talk, but you can see here this ossification along the spine. You can see the osteophytes beginning. You can see bridging here. These are the kinds of things that group studied and scored. In terms of correlation, we'll look here at what's called an ossification index, which is a summed score of the ossification of the anterior and posterior longitudinal ligaments and a third spinal ligament, the yellow ligament. So this is kind of a amalgam of the spinal ligament calcifications, and that ossification score is highly correlated with age. It also correlates to some extent with the bone outfos, but this is variable because the total outfos was not a significant correlate. Interestingly, knee osteoarthritis score correlated with the ossification index. If you look at what correlates with the hip or the knee ossification index, it's pretty much only age. So all of these markers don't really tell us what's going to happen. What's going to happen is you're going to see this change, at least in this cohort, primarily on the basis of age. Now, a third study based in France also examined even more adult XLH patients, 114, and they had careful examination of images as well. They also had the genetic data and the nature of the mutation infects in these patients, and they also had the benefit of dental scores due to thorough dental examinations, and were able to correlate the spine changes with the teeth changes. The enthesopathy was scored at the spine, the pelvis, and the heel. They looked at various clinical laboratory and demographic variables as well. You can see here, this is shown a little bit differently, but the percent of patients affected are on the y-axis again, and the decades go across the x-axis. But we see 3 columns at each age group, and they're broken into cervical, lumbar, and thoracic spine. And what I thought was novel from this data set is that at every age group, the cervical spine was the most severely or most extensively involved, a little bit less for lumbar, and the thoracic being the least of these 3 groups. Furthermore, there was no correlation of any of this enthesopathy with the type of FEX mutation you had. You could have the whole gene disrupted, you could have a missense mutation in a small part of the gene, and there's no impact on the severity of this. Like in the previous study and in the older studies that were just mentioned in the previous talk, age was the strongest correlation. But there was also, interestingly, a correlation with dental complications. Finally, and you'll hear more from Dr. Masisa about this later in the afternoon, another study looked at the combination of these musculoskeletal findings and the impact of this on gait problems. This just being one figure from that paper that displays the characteristic lordosis and compensatory kyphosis that occur and how that axis, the mechanical axis is thrown off that ultimately affects gait. And Carolyn will talk about that in detail later, I'm sure. So the next area that I thought was particularly emergent over the past 3 years was that of how we can improve our transition from taking care of children to life in the adult world with XLH, and how to effect the smoothest way to manage that. Now, I think one way to do it is to send your patients to Indiana, where Dr. Immel is the transition point from the pediatrician to the adult care. In fact, he is the pediatrician and he is the adult care, so they have a seamless movement there. There's a nice study in JCNEM that, based on good evidence, breaks down the problems of each age group, what happens at the provider level, what parents need to be aware of, and they have a recommended course, which I think it's worth people looking at. This comes from Nashville, Dr. DeHeer and her group. And I'm just going to show you a few elements that are in the publication that I think everyone that's in the process of maturing their patient population should look at. You can see here the items that are pretty much specific to pediatrics listed. You're initiating the therapy, you're monitoring growth, you might have to do some guided growth procedures. And then in adolescence, you've got to worry about compliance and continuing medical therapy. It really becomes important to consider the psychological and psychosocial elements of the disorder. There are things that really overlap between adolescence and pediatrics, and then as you move into the adulthood area, things that overlap between adolescence and adulthood, and then the adult-focused issues, including monitoring for the stenosis and the enthesopathy, how you deal with pseudofractures. They're much more common in the adults than in the pediatric age group. And this paradigm is what this article addresses. They give an example of a child who was followed pretty closely through the first 8 to 12 years of life, has a surgery at age 12, but then sort of disappears and is lost to follow-up. Shows up a little bit during the late teens, 16 to 18, needing another surgery, but then again is lost to follow-up until they're 25 years old. And it's this gap that can create a lot of the long-term problems. The 7-year gap in this particular patient's course resulted in persistence of lower extremity pain. There was significant psychosocial impact in the case study. The emergence of opiate dependence, Achilles tendon tears, more dental problems, problems with employment. And if this list can be shortened with a better transition, I think we'll be doing everybody a favor. Their simple approach to getting this started is to devise what's called a transition passport. And having to renew my passport for my first international trip this week, I understand the attention a passport can get. But they basically list the various demographic pieces on this passport, but then they provide a lot of important, in a checklist fashion, a lot of important clinical data that occurred in childhood that can be then taken to the adult care person and then with a list of, like, you know, I got into trouble and had to call the American Embassy. Well, you know, your support groups are all here too. And so I think this approach is probably going to need to be individualized at every different center, but I think it's a really important concept and a paper worth looking at in greater detail. So the osteomalacia story, this comes from the one-year study of treatment with burosumab that Dr. Insonia spearheaded. And this was a single-arm study. Everybody was on drug. They were treated with the standard doses of 1 milligram per kilogram every 4 weeks. They had not had any treatment of any kind for the 2 years prior to entering the study, and there were paired biopsies in 11 subjects. And here you see the classic histomorphometric changes that were seen in this study. The osteoid volume over bone volume drops. The osteoid thickness drops. The osteoid surface over the bone surface drops. And the mineralization lag time drops, although statistically, I believe it was only the osteoid thickness that ended up being statistically different with this small number. And you can see the tremendous variance in all of these measures that also impacts how one interprets the statistics. But this is just sort of an example. You can see the extreme accumulation of the red staining osteoid on this before treatment biopsy, and in the same patient, most of what you see is a thinner osteoid. There are some areas that remain somewhat thick, but overall, I think it represents what you see in the overall data. The assembly of the growth data is interesting, and these data were collected from 4 XLH studies, a total of 238 patients, but with nearly 2,500 measurements. None of these people were treated with burosumab at the time these height measures were taken. Nearly all of them were on conventional therapy at the time. So these are the boys, and you can see in black the centile lines of XLH boys from 1 to 13, and they're superimposed on what the normal population growth curve looks like in blue. You can sort of compare the 50th centile at the heavy black line versus the heavy blue line. Now I want you to focus on just the first 5 years as they're called out in this slide. And you can see that that divergence doesn't occur till about where that red arrow is pointing. The black and the blue heavy lines are superimposed till you get to about 10, 11, 12 months. And then the height defect starts to emerge. So as just pointed out in the last talk, you're not born short. It takes a while for that to emerge. Now also you can see, maybe better on this slide, there's hardly any subject that was greater than 50th centile for the males. And here you see the girls, the same idea, although there's more variance in the girls' heights. You can see several of these dots showing up over the heavy 50th centile line for the girls, but when you just look at the first 5 years, you see that same divergence beginning right at the first year of life. This is a website that I think everybody may want to copy down the link to. It is the assembled and complete revised database of the mutations in FEX. This is a screenshot from the database. It's really nice. You can scroll around and look at the gene. You can look at the protein. You can enter your mutation. You can see how many people have been reported. It's constantly updated. And it's the biggest source of genetic information about FEX mutations that's out there now. And it is periodically updated. The long-term outcome data. So there is now longer-term outcome in both children and in adults. The childhood data really reflects that very first study in which children were randomized to every 2 to every 4 weeks, and then after the first year, everybody put on every 2 weeks. The original cohort completed the whole 3 years of this, and biochemical data, limb deformity scores, and patient-related outcomes are all in that data set. Here is the biochemical serum phosphorus levels. You can see, I think everybody sort of has imprinted these first 64 weeks where the every 2-week doses climbed after titration to get into the normal range, and there's the up and down pattern that you see. If you're getting it every 4 weeks, you drop back down. But all of the trough levels even higher than baseline. Well, at this point, everybody was crossed over to every 2-week dosing given the steady state nature of the serum phosphorus levels, and those levels have stayed pretty much as they were achieved out to week 160, or 3 years of therapy. So the durability of maintaining the serum phosphorus has looked pretty good. Now, the X-ray changes are interesting. This being the every 2-week group, this being the every 4, and this being everybody together. But in all of these, the story's pretty much the same. You get that correction by 40 weeks of the epiphyseal changes, the fraying and so forth at the edge of the metaphysis. And it holds, but it doesn't seem to get a lot better. It holds at a partial correction. Now, in contrast to that, if you do a score that isn't looking at the epiphyseal fraying, but actually looking at the deformity with a variety of different ways to score it, you see an effect that's early but mild, but at the 3-year point, you're still getting better. And so it speaks to that problem that I think we all address when we're taking care of patients, that we see a change on the X-ray at the epiphysis, and we're happy because that's working, but the parents aren't seeing that. The parents are seeing the continuation of the bow defect. When is this going to change? Why is this taking so long? Oh, we're happy the X-ray's better, but it's going to take longer for that to happen, and I think you see that in this data here. What we don't know is this going to continue to improve? Is the deformity going to continue to improve even after 3 years? The alkaline phosphatase levels shown here, and they're in the normal range and staying there, so that durability of that finding in the children is strong as well. With respect to patient-related outcomes, we'll focus first on the right panel, in which the global score of this survey is shown. The average score for the normal population here is this line at the 50 score, at the 50 unit level. And you can see that at entry into the study, the XLH patients were well below that. In fact, 2SDs is the 40 line, and they were scoring below that at 38. And then at various points, week 40, 64, and now out at 3 years, there is an improvement and a continued improvement such that at the 3-year point, the score is at the median of the normal population. Now, this global score is really driven by 2 domains in this questionnaire, and that is the pain, comfort, and the sports physical domains. And you can see these are actually lower than many of the others at baseline, but both of them are continuing to increase and nearing the median for the normal population. So at least in these subjective measures, there seems to be not just sustained, but continued improvement in well-being. In adults, there's a recent paper that looks at some 2- and 3-year outcomes. Most of this is patient-related. However, there are some biochemical data and some fracture data that are reported in the paper. Some of this, I believe, was available at the time the group last met. You can see here the serum phosphorus levels in the placebo group. This went on for 24 weeks versus the rapid correction in the burosumab treated group, and then the placebo group is crossed over to drug, and similar pattern occurs for both. Now, the 125s are similarly affected. The serum calciums don't change very much. And there's a little movement, perhaps over a long decrease, but certainly no further increase in the PTH levels. I think this remains a variable issue, and each patient still needs to be looked at because I think there's a lot of patient-to-patient variability in PTH response. This classic slide shows the fracture healing of fractures and pseudofractures that were evident at baseline. And in the burosumab-treated group at 24 weeks of therapy, there's a 40% healing, whereas the placebo group only achieved a 7% healing. But when this placebo group was crossed over to drug, they began to do exactly in parallel to what the initial exposure to burosumab did in the originally assigned treatment group. Now, what now goes out to 2 years in the adult population are the WOMAC scores. You can see that there's durability to their total WOMAC score, the domain of physical function, the domain of stiffness, and the domain of pain in both of the originally assigned groups. But this is holding up so that the general well-being appears to be at least durable for 2 years. You can keep going with these. You can see that they're pretty much continuing to improve or holding their own, even if you ask, what's your average worst pain, your greatest worst pain, etc. In the interest of time, I'm not going to dwell too much on that. But this one is the one I thought we ought to try for the next fatigue therapy for XLH, particularly while we're here in Dublin. I'm going to wrap up by simply saying that there have been considerable advances on the clinical side in understanding XLH since the last symposium, but there's a lot left to do, and we are anxiously awaiting longer-term outcomes and the potential for optimizing treatment and living conditions for this disorder. Thanks.